So again, I'm Tasha Gastony, and I'm a physician assistant with 20 years of experience. I'm going to give you two perspectives today. One is my perspective as a PA and the future of the workforce, and the other will be about the work I'm doing in smart care. So I read an article in our PA journals a couple weeks ago that said that 75% of PAs are going into specialties. And we know that it's good for him, but
It's good to be a specialist.
I know we're concerned about the doctor shortage for primary care, but I'm also concerned about the NP and PA shortage that could occur in primary care, and that's twofold. I think the reason for that is the programs are great, but the patients are complex. And Dr. Neal and I have worked on trying to create a program so that NPs and PAs coming out of school can have some more additional education. I actually traveled to North Carolina and visited a fellowship program. That was phenomenal. But we see at these new graduate NPs and PAs that they really, really struggle in their first or second year of practice. And after leaving a practice of 20 years to open smart care, as a new graduate, I could never have stepped into the practice that I left. And the other struggle with that is doctors are so busy that they're reluctant to want to take on an NP or a PA to help with that training. So I just want to put that out there, and if you guys have questions about that later, we can talk about that. The endeavor I'm on right now is being a clinical lead in our clinic called Smart Care. And smart care is driving toward the quadruple aim. We all know what the triple aim, the fourth tier is better clinician satisfaction. And we are offering technologies such as telephone visits and video visits. And we have 4 RN clinicians, which is a new role. And basically, the role of the RN clinician is that they're operating in a retail, what you might get at a retail clinic from an NP or PA, and operating off of standing orders. We will have, and one of our new PAs is in the audience, we will have 4 PAs. We haven't had any NP interest, so there isn't any reason why we really wanted a balance, but it just didn't work out that way at this time. So we'll have 4 PAs, and then we'll have 2 MDs, and they're about 1.5 FTEs on the MDs. And we're functioning in a way that we have a shared panel. I'm actually the PCP, and that's only because of EPIC limitations. So when patients decide to be attributed to smart care, they are signing up for a true team of patients. And when they decide that they want to commit to this 2-year pilot, we make sure that we really spend a lot of time up front really making sure we know who their specialists are and what their problems are and what the care plans for their problems are. And we are not thinking of things in terms of having physicals for patients anymore, because each and every time the patient has an encounter, we're constantly looking at the HMAs and EPIC to make sure if it's a PAP or mammogram or colonoscopy or tetanus shot that we're capturing it as we move along. And once a patient has chosen to be attributed to smart care, we really encourage them to utilize MyChart more than calling us. The phone calls come directly into our clinic, so we're bypassing the call center. And that's an important piece of it because of the navigation toward whatever level of care is needed for that patient, which could be a telephone visit or a video visit or an RN clinician visit by a standing order. And the great thing about the care model is if the patient is being seen at one level of care and suddenly we realize that it's too complex for that level, we can immediately take it, change the provider, and move that along. As an experienced PA, I really appreciate having an MD available all the time. And ultimately, we would like to get to a point where the MD functions still seeing patients, but functions in a supervisory role, not only for the NPs and the PAs, but for the RNs that are on the phone. We share a team space, so we're all working together, and just sitting back with the nurses while they're taking phone calls, we've diverted so many appointments that would have been, well, I'm not exactly sure you need to be seen, because it falls just slightly out of their protocol for a UTI or something like that. So it has been a really nice and fun project to be working on. We need more patients to really test the care model. The video, I did my first telephone visit for diabetes this week. It was a patient that's been stable and was seen 6 months ago and had an A1C of 6.1. And I really wasn't going to do much for this patient in a face-to-face visit, so we did a touch-based telephone visit. I did notice she had one elevated blood pressure at an urgent care visit, so I asked her to go into the nearest Park Nicollet clinic and just have her blood pressure checked to be certain that that wasn't falling out of range for our goals. So one story that I'll leave about Smart Care, because I'm sure you'll have questions about it. We had a patient that came in with appendicitis that had ruptured and was admitted to Methodist and placed on IV antibiotics. Followed up, she happened to see an MD in clinic that day. Followed up with me the next week and was doing great on her oral antibiotics. And then I was working on a Saturday morning, and she called our clinic and they said, she's got a rash. And I said, well, it's probably her antibiotics, but I don't know for certain. And the problem was that she was halfway between here and northern Minnesota. So we asked her to pull off to the side of the road and download the video app where we could actually see the rash. And I confirmed, yes, it's a drug rash. So I called the surgeon, who said it's fine at this point to discontinue the antibiotic, and the patient went on her way. So I think we avoided an urgent care or an ER visit in that case. So it's pretty good.